Y'all, I'm literally sick. I'm so sick. I'm sitting here on Juneteenth, as you can see via the t-shirt, about to get ready to drop a video since I launched my channel 3 years ago. Very intentional, right? Hello blackness, hello freedom. Here we come, here we go. And I'm at the part of the video where I'm talking about, all right, I just left my exam. I feel really good about it. I never felt this good walking out of the exam, blah, blah, blah. My friend texts me. It comes to my watch. I feel a little triggered. I check my email because, mind you, I be checking my email all morning of the day that we get exams. My very first exam, I said I was not going to check because I know you get a pair message if you fail, because things happen my first year and I got a lot of pair messages. So I was like, if I fail, I'm gonna get this message. I got a pair message. I was like, well, I failed. And that pair message was for something else. It wasn't even bad. And I was like, this is a trauma that comes with medicine. Like, just got me shooketh. So NBME sends this email talking about insights, your score is available. I click it. My passwords are all auto-populated because who the heck can remember passwords? Like, I just don't understand. Go to the website. It's not auto-populating. I'm like, what is my password? What are we doing? Like, what are we doing? And then I go to this other website. It's not up there. It's not on Benware, which is my school website. Then I go to this, what is this? University of Illinois College of Medicine. It's like a services website where you can see what your rotations are, what you've got in, blah, blah, all this stuff. And I'm just like, yo, what's going on? So I log on there and I passed. And I've never passed this much, like this many points above the minimal pass level. Like, I knew I was gonna pass, but it's still traumatizing to even look for the score. So, yeah. Hey y'all, welcome back to Madeittomedicine with Vix. That is me. I'm a real life person. I'm a third-year medical student at the University of Illinois College of Medicine. I come to you weekly with videos about my pre-midterm med school life, a little bit of everything in between. Like, literally, this is my real life. So this is a real lifetime reaction. Like, it's practically right after I literally just checked my score, y'all. Like, scores come out the Wednesday after the exam, typically at 6 a.m. I got that email at 10:40. Like, what are we doing? Is it because it's a federal holiday that the girls are late? Like, y'all should have set out the scores a day early, but okay. So yeah, in this video today, I'm going to walk you through my experience, give you my true reflection of internal medicine, what I think of the field, where things are gonna go from here. Is this really a possibility of a field or specialty for me? Because from internal medicine, which they primarily see adults, they do not see children at all. But this is the field where you can specialize in all the different things: oncology, cardiology, pulmonology. You can even go to palliative care from here, but I think you go to palliative from other things as well. But GI, so many specialties come from here, rheumatology. And I'm gonna just walk you through the little bit that I know, because I'm not gonna lie and act like I know everything, because I do not. But let me catch my breath though, because I'm still a little shook. And medicine has me scarred, yeah. So clearly it took me quite some time to catch my breath, as, yeah, it has been almost 2 weeks since I recorded that first clip. I don't know, I'm on vacation essentially, and I needed some time away from not just thinking about the rotation, but even discussing the rotation, because it was really a lot for me. So my assessment of the rotation, I had to do all 8 weeks at University of Illinois Hospital, which is my school's hospital. And most people would do 4 weeks at a community site and 4 weeks at UIH. And the community site is supposed to be like the more chill version. I think everyone still works like 6 days a week, but I hear it's chiller than UIH because we just have a high volume of patients. Your team service is likely capped, and I believe capped for us at UIH is 20 patients. So the team consists of an attending, a senior resident, 2 interns, and then 2 M3s. Of course, I was one of the M3s on the team. Oh, and we also had a sub-ISO, which is a 4th year medical student completing their sub-internship. They're likely to be applying to the field of internal medicine. So that is a team of 3, 6, 7 people. And the attending is not there all day. So they come in for rounds, and when they come in for rounds, that means that you should have already seen your patients, already written your note, and are ready to present the patient. So typically we would round around 9 o'clock, 9:30. And on internal medicine, general side, we arrived at 7 a.m. Hearing a 7 a.m. start, initially I was like, okay, okay, this isn't too bad, because I was coming off of pediatrics and my last 2 weeks were in the newborn nursery and I had to be there at 6:30 a.m. and that was very, very hard for me. I think I was waking up every morning at like 5:15 on days I was pushing it because I was unable to eat that early and I had to like bring my breakfast to the hospital. So I was like, okay, 7 a.m. is it going to be that bad? Because like it's an extra 30 minutes of sleep. No. Internal medicine is very, very demanding, and every 5 days you have long call, which I previously told you is you are there from 7 a.m. to 7 p.m. So everyone is accepting call unless you're on your no call days, right? And I think at 4 p.m. it's either 3 or 4. Like, I can't believe I'm already forgetting this information, but let's say at 3 p.m. all the other teams, they stop admitting patients, and now solely your team from 3 to 7. It's either 3 to 7 or 4 to 7 p.m. You're admitting patients. And a new admission means like someone could be transferred to your floor, or someone literally came into the emergency room and they need to be admitted to medicine. So you have to go down to the ED, take the patient history, type up the entire note. So you're typing up a history of present illness, looking at their vitals, their objective vitals. So, you know, like their blood pressure, heart rate, temperature, and then doing a physical exam, and then coming up with an assessment and plan. So they come in with this concern. You figure out, okay, these things are on my differential. They either have the flu, they either have some type of viral infection, bacterial infection, or whatever. So you make this list and you also compile it with all of their current medical conditions. So someone could already have COPD, or already have asthma or bronchitis, or some type of cancer, or heart failure, hypertension, diabetes. All of that also goes in the assessment and plan. So when you're first admitting a patient, honestly for me that takes the longest because it's just like a lot going on. Typically, for every morning when you're coming in, you're just doing a progress note. So it's like you already know what the problem is. You already know why they're here. And in your mind, you have created, okay, these are the barriers to discharge. How can we overcome said barriers to get them out of the hospital? So progress notes. For me, I would come in those first 4 weeks, and if I would only have like 1 or 2 patients, I was done with everything by 8 o'clock. And I was sitting around for about an hour 15 minutes waiting for the attending to come so that we could round and update the attending on all of the patients that we had. So that was general internal medicine. I will say that I did learn so much, like so much on that service. Just little things that I didn't even think about, or things that I've been avoiding for so long. Like diabetes is so big, especially in America. A lot of patients have diabetes, type 2, and high blood pressure. So I got really good at those medications. What's the treatment? What's first line treatment for hypertension or diabetes? I was never good at the medications because pharmacology just really isn't my thing. But it's so different from just studying it solely on your computer all day, reading practice questions or reading in a book. Then like, okay, your patient comes in, they're on metformin at home, but we don't give metformin in the hospital, so you have to give them insulin. And knowing how to do the conversion factors of how much insulin do you give them for long-acting or short-acting insulin. So that was pretty cool. I won't say that I'm amazing at it just yet, but I'm 10 times better now than I was week 1, week 2, week 3 of internal medicine. This was the first rotation that I faithfully took a lunch every single day. The residents have noon conference, so from noon to 1, I would go on lunch because the residents are gone. So, and by residents, it was mainly the interns that would leave. The senior would stay, sometimes they would go as well. But that was time for me to go on lunch. So for my lunch, I am so big about protecting my peace, protecting my energy, protecting my mental space. I walked out of the hospital. Initially, I was eating lunch in the hospital, in the cafeteria, and then I was like, actually, I don't want to do this anymore because I don't want to see people, be like people that I wanted to see or people I didn't want to see, because technically I don't want to see anybody during my lunch because it's my free time. I'm going to choose who I want to be with. So me and my friend, we would go over to the College of Medicine, find a room, we'll sit down, debrief if we had a hard morning, or just catch up on life. And very rarely we would study during lunch because, again, no. But I was proud of myself for protecting that hour because other rotations, I wasn't really good at that. Family medicine, I could have taken an hour, but sometimes I wanted to show that like, I am such a great student that I'm gonna skip lunch to work up these patients, which my evaluations did show that I was really good and I was for the team, but also, because both things can be true, me not eating turns into misery. Like I can get a headache or I'm just kind of like flustered. And it's just important to take your lunch. Like in a system where it's almost encouraged to work, you have to continue to pour into yourself equally as much as you're pouring into your patients or pouring into those around you. So as I've gone further in rotations, I've learned the value of actually taking my lunch and taking my lunch away from said team, because it's very easy if you stay in the team rooms to work during lunch, and I like to not do that and still get my work done though. Like, I never left the hospital having to complete notes. So that was a beauty on internal medicine. You're not constantly seeing patients throughout the day. You mainly round on them in the morning. And in the afternoon, you're kind of chilling, like whether the resident wants to teach you something or you asking questions to figure out like a complex patient case, or asking to pick up new patients. And then for the next day, then you have more to do in the morning before rounds come. So that was something like a little balance, something I was not necessarily used to, because when I first started internal medicine, I'm like, oh my gosh, we're doing all these things in the morning, so why am I still here in the afternoon if I'm not seeing any patients? In retrospect, I wish that I'd asked to pick up more patients in the beginning, because then my time would have been better utilized. But there's a lot of downtime, so you have time to do practice questions. I did UWorld. If the workroom was loud though, it's very difficult for me to do UWorld because I just like need that silence to focus. And then when I moved to oncology, it was a different dynamic. So internal medicine, all the patients are basically acutely ill. Well, oncology is different because like they have cancer on top of all of their other medical diagnoses, and some patients were newly diagnosed with cancer and actively receiving chemo or radiation. Some were coming in because of an infection due to them being immunocompromised, immunosuppression because of the cancer, or some could have been completely unrelated, but they were still transferred to our unit because they have a cancer. So these patients, it was really hard. My very first patient, day one patient was, you knew that they were ill because they're in the oncology department. But then by day 3 that I had them, it was such a quick decline, and conversations had to change with what we were talking to the family about, because they just weren't responding and it didn't seem like there was any other treatments that we could do to prolong their life. And so we had to switch from palliative care conversations to hospice care, and likely inpatient hospice, which means that the patient has roughly 2 weeks to live. And I'm a very emotional person, and that took a big toll on me to not only like come in, I'm always caring about the patients, asking how did you sleep last night, is there anything that I can do for you, if there's anything that you can think of. And I even tried to like spark the conversation, say something, Jill, if you need an increased pain management, if you need some ice chips, if you need your meal, your nutrition to be changed, if you want to talk to a chaplain, if you want to talk to social work, you want to speak to the attending, I give them options because I'm here to serve you. And it was really painful to go from hearing them speaking in a regular voice to barely whispering. And I spoke about this in a previous video. I cried in the room when their family members were in the room, and the conversation did shift to end of life comfort care that was ramping up very, very quickly. And when I spoke to the residents about it, they said it's okay. Like, this is very, very difficult. It's not easy to deal with. It's not easy to talk about. And I'm human, so it's okay to show my emotions. And it was okay to cry. Like, I told them that I was low-key embarrassed that I was in the room crying. They said, Vicky, it's fine. It's okay, and that actually shows that you care. It showed my humanity. But from there, it didn't get easier, because when, as a kid, if I thought of like someone having cancer, I think of someone like that's older. And if they die, like, yes, it's still sad, but they've lived a life. But when you get cancer patients who are young or middle age, it's really hard, especially when things just kind of come out of the blue. You were completely fine one day and then the next day you're not. I will say that on this rotation, the second half, so the first half was 4 weeks and the second half was 4 weeks, that it was a lot of showing me that it's okay to be a person, showing me that it's okay to feel my feelings, showing me that that is one of my best attributes of connecting with the patient and showing them my level of vulnerability, because they are completely vulnerable in this time, in this space, because they're outside of their home. They're in a hospital. No one wants to spend a lot of time in the hospital, so you're like trying to make the best of it, out of it. And on oncology, although internal medicine does this too, but oncology, it's more of, I saw a lot of the interprofessionalism. We do a lot of consulting via the Epic chat, secure chatting, communicating with different teams, whether that's infectious disease, neurology, neuro-oncology, GI, gen surge, whatever specialty that the patient needed. We'll be consulting with them, and then also, palliative care, because they more so handle like the hospice route or comfort care anyway. And then social work for sure. Like there are some patients who were in the hospital for a while and then going home, they need like hospital bed or homemaker to come and help prepare their meals or help them with cleaning or get home physical therapy and occupational therapy. So we were in constant communication with all of these different teams, which showed the grand scale of interprofessionalism. And although in general internal medicine, we did have a pharmacist in the room, they would just come during rounds. For oncology, we had pharmacists the entire time while I was there. And then I think my last 2 weeks, there were pharmacy students. And I will say that was probably a highlight of the rotation, because it's something about being around people who are in the same space as you. They understand what you're going through, and I felt more comfortable asking them questions about drugs than I did asking like the resident or the pharmacist, or they felt more comfortable asking me questions about, okay, like which patient are we on again? And what was the update overnight with this patient? Like, it just showed me in the future what my life would look like interprofessionally, working with different disciplines within the healthcare system. And I really enjoyed that. And when I told them, they're like, oh yeah, my last day is on Wednesday. They're like, oh no, I thought you had another 2 weeks with us. Like, what are we gonna do? I'm like, oh, it's cool. Like, we're off the day before our shelf exam. We have the exam on a Friday, and then there'll be new students on Monday, and I'm sure they'll be equally as great. It just showed how we as students, like, we kind of like band together. Granted, I've never worked with pharmacy students before, but that was so cool to me. Overall, I will say that internal medicine is like the foundation of all rotations, because you learn so much. You learn it in depth, in great detail, but it is not the field for me, mainly because of the patients are acutely ill. Like, they're very sick, and some are like so acute that it can turn to chronic illness where it just trickles down, and they can be like, I said my first patient was appearing fine the first day, not like fine, but they were sick but speaking. And as days went on, you had to get very, very close to hear them. And I think that professionally, if I chose this field, it would be an emotional roller coaster for me. I did have some really, really good advocacy moments for patients, where I had to advocate for different things to be received from the nurses, or advocating with social work on getting patients transferred to rehab, or just advocating to my team about the patient and what their needs were, because as the medical student, you see the patients more than anyone. Like, I go into the room, I see the patient first, then the intern goes into the room, they see the patient, and they do a quicker assessment, because if I only have 1 or 2 patients, interns can hold up to 10 patients at a time. So their assessment isn't as in-depth as mine is. So it's very important for me to not skip steps, pay attention to all of the details, and then bring up what I've seen and not be afraid to do that. Like, it's okay if I bring up something I didn't think was important, because one time I brought up something and I didn't really think it was that deep, but the team did, and they were like, oh, that was a good catch, that was a good save. And meanwhile, I'm just like, oh, I'm just going through my checklist and trying to be thorough about it. So medical students really do have a big role in the team, and you'll see the patients the most. You'll spend the most time with the patients. And like, even after you round with the attending midday, and like, I did table rounds and walking rounds depending on the attending. The attending switched every 7 to 14 days depending on who the attending was. And let's wait for that to pass. And I would say that a perk of internal medicine, like, I really do enjoy clinic and all the rotations I've had that had clinic, but clinic moves very, very fast, so you don't get as much time as you'd like to be in the room with the patient, because you're constantly rushed, because appointments are booked every 10 to 15 minutes. For internal medicine, there are no appointment slots because you're in the hospital. So if I forgot to ask a patient something, I just get up and go back to their room and I ask them again. And throughout the day while I'm on shift, I'm checking their labs, checking their vitals, any updates. And so if something changed, then I could go back to their room and say, okay, well, how are you feeling? And okay, we're gonna make this medication change. And if you notice this, or this happening, please let your nurses know, and they will contact my team, and I will come back again. Like, I could go see the patient as much as I wanted, and that part I did love. I love not being rushed. I love being able to take the time to converse with the patients, and I actually could sit down in the room with them if I'd like, and provide that level of comfort, making phone calls to family to update them on what's going on, learning how to give a consultation over the phone. And I really enjoyed that. And I love the autonomy, right? Like, someone doesn't come in immediately after you. That part was beautiful. And then what was hard though is constantly giving presentations and learning to not be so nervous to give them in front of a room full of people, because in the clinic you're only presenting to that one person. You're presenting to the resident or you're presenting to the attending. On table rounds, everyone is listening to your presentation, and I had to not take it personal when people were interrupting me during presentations, because my job is to show you that I've done the work and I'm coming here and I am prepared. But on the other end, I did appreciate when some attendings allowed medical students to pause and to think about what was going on. Like one attending in particular asked me a question and I stopped and I paused and I was like, oh my gosh, I'm so sorry, I'm taking so long. And they were like, no, take your time. Like, I know you know this, just think about it. And when I couldn't get it immediately, they prompted me a little bit and then I got it right. And they were like, yeah, I knew you knew it. You just needed some time to process it. Like being a good team player and being a good teacher, being a good leader, I believe goes so far, because as a student, it's very stressful. You're carrying so many hats. The student trying to learn in the hospital, the student trying to study at home to pass said shelf exam to move on to the next rotation. There's just like so much that went on with internal medicine, and I learned a lot about the type of resident doctor that I want to be to medical students moving forward, and I also learned some things of the type of medical doctor or resident that I don't want to be moving forward. I am here for whatever the person needs. Like each student is going to be different, so things that I walked away with enjoying about internal medicine, someone else could have hated all of that because learning styles vary. But I'm here for being adaptable to change and molding to shape shift to whatever the student or whoever needs. So I'm still gonna tell you, whatever rotation you're on, ask for expectations on day 1, day 2, and also something that I'm learning, ask for feedback. Ask for feedback as you're going, because at the end of the rotation, every single attending and resident will give feedback, and the best feedback were those that I was getting on a daily basis, so at the end they could say, okay, I've been giving you this feedback and I saw that you were changing, or you weren't and you probably need to pick it up in this area. But don't always throw all the cards in someone else's hands. Like after 2 or 3 days and you've been doing this and you want to tell them up front, like, hey, these are my goals, I really want to work on my power statement, and I really want to work on coming up with a assessment plan and being concise and succinct and giving my presentation. After 2 days, hey, how's it been going with my power statement? Is there some way that I can improve? Not only does it show that you're proactive, it shows that you're willing to learn and you want to make changes. So these are some things that I'm going to walk away and going on to my next rotation. And if I can think of any other pointers or tips, I'll be sure to do that. And I also think I'm going to do a video on how to make a consult call, because that resident who taught us that, I'm like, wow, this is golden, because some interns didn't even know how to do it. Like some people are just great teachers naturally, and I do think that others can learn. If there's anything in specific that you'd like to know about my internal medicine rotation or the internal medicine shelf exam, please be sure to leave me a comment down below. Let me know. Oh yeah, hit the like button, the subscribe button, drop a comment, do all those things, and I'll catch y'all next week's video. Bye y'all.